Good afternoon, and thank you everyone for joining us. My name is Steph. I'm a research fellow at the Matilda Centre for Research in Mental Health and Substance Use, and it's my great pleasure to welcome you to today's Cracks in the Ice webinar. Before we begin our webinar, I'd just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people and pay my respects to their elders past and present. And I'd like to further acknowledge the traditional owners of the country on which you are on today and pay respect to their elders, past and present. So today's presentation is one in a series of webinars, which is running as part of the Cracks in the Ice project. So if you're not familiar with Cracks in the Ice, we run these webinars every couple of months. And if you haven't already seen the website, I'd encourage you to go visit cracksinttheice.org.au. And we welcome any questions or comments that you may have. So feel free to get in touch with us at any time. Before I introduce today's speakers, I just wanted to let you know that as participants, you are in listen-only mode. And that means that we can't see or hear you, but you'll notice that on your dashboard, you have a Q&A button. And this is where you can type in any questions that you have throughout the webinar and send them to us. And we'll also be having a dedicated question and answer section at the end of this webinar presentation. So please send through any questions that you'd like to ask the presenters through that Q&A box. We are recording today's session and we will be making that recording available to you via the Cracks in the Ice website in the next couple of days. So I also have some exciting news. Cracks in the Ice has recently joined LinkedIn. So if you are also on LinkedIn, we'd love to encourage you to follow us. We're hoping to post content, but it's also a great way of keeping on top of what's happening in terms of future webinars and social media, all to do with methamphetamine. So without further ado, I'd like to introduce our presenters for today. So we have Dr. Rose Crossin and Dr. Jai Whelan. So Rose is a senior lecturer in the Department of Public Health, and her research focuses on understanding and measuring drug harm and the ways in which harm can be reduced from a public health perspective. Harm reduction principles are key to her research, which also has policy and practical impacts. And Jai is a postdoctoral fellow, harm reduction advocate and drug user. He's interested in a broad range of health research topics, although his primary focus is drug studies. He's particularly interested in research that pertains to harm reduction, drug policy, lived and living experience, and the intersection of these areas in Aotearoa Maori. So thank you both for joining us. We're so grateful for your time today. It's going to be a really interesting session. So I'm going to hand over to you now to take us through the webinar around a public health approach to reducing methamphetamine harm in Aotearoa, New Zealand. Thank you.
Thank you. I'm just going to quickly get the slides up. Do you want to introduce yourself, Jai, while I faff around and get slides ready?
Kia ora, ngā mihi nui kia koutou katoa, ko Jai tōku ingoa, he uri ahau no Ngaitarangi. I think I would just like to, if I could, start us off with a brief karakia. So it's kind of like our way over here of doing our acknowledgement to what we're about to do, the space and the work that's going on, and just puts us in a culturally safe space to do that. So tuku atu wairua kia rere ki ngā taumata hei arahi i a tātou mahi me tā tātou whai ngā tikanga a rātou mā kia mau, kia ita, kia kore a ingaro, kia pupuri, kia whakamaua, kia tīna haumie hui e, tā ki e. So, ngā mihi nui ki a koutou, ngā mihi e te rangatira mā o te whenua moi moi my acknowledgements to you chiefs of the dreamland of Australia. Kia ora.
Kia ora, I'm Rose. Jai and I are going to be alternating the presentation between us today and bouncing off of each other. We've been working together for a few years now, which has been really wonderful. It is Friday afternoon here, and I feel like this seminar came up on us really, really quickly. So I am feeling a little bit glitchy this afternoon, so bear with us, and I hope that we have a really good conversation. Just want to acknowledge too that this work involves another colleague of ours, Professor Joe Bowden, but it is Jai and I here with you today. So, right. If we think about methamphetamine use and supply in Aotearoa, New Zealand, there is a fairly high supply here at the moment, I guess similar to Australia. Um, Over 5,000 kilos has been seized by customs in the last year or so, but prices are also declining, suggesting that there is high supply in the community. Survey data from the drug trends surveys tells us that there's increased frequency of use and purchasing, and wastewater testing is consistent with this idea of a really high supply in Aotearoa at the moment, with almost 35 kilos a week in Q4 of 2025, which is our most recent data. We in New Zealand, you in Australia have such wonderful data compared to us. Ours is really rubbish in comparison. What we do have is the New Zealand Health Survey, which the most recent findings show that about 1% of those aged 15 or over have reported methamphetamine use in the last 12 months. So in relation to New Zealand population, we're talking about 42,000 people. When we think about the demographics of people who are self-reporting methamphetamine use, men are more likely to report methamphetamine use in the last year than women. Māori are more likely to self-report than non-Māori. Those with disabilities are also reporting higher rates of use. However, at the moment in New Zealand, there's not any evidence of a socioeconomic relationship, and it is across the New Zealand community. So we have an estimate from a piece of work that's published every few years by the National Drug Intelligence Bureau, and they estimate that there is almost 1.8 billion of social harm estimated for 2025 from drugs, including from methamphetamine. And when we think about harm from methamphetamine and contextualizing this from a public health perspective, we are obviously interested in harms to self, and that includes medical harm and psychological harm and addiction or dependence, but also some of those wider harms to self, including things like tangible losses, loss of job, loss of employment, loss of freedom from incarceration, and also the relationship damage that can occur. So a broad understanding of harms to self. When we're thinking about harms to others, again, we're trying to think about harms more broadly. So we're considering injury, and family harm and economic cost, but also the fact that it's a Class A drug in Aotearoa, and so there is crime associated with a black market that is attributable to methamphetamine, as well as the wide damage that occurs to communities, and communities who are stigmatized and judged or associated with methamphetamine use, and it sort of perpetuates stigma and marginalization. So a few years ago now, we published a drug harms ranking study based on the work that David Nutt did back in and published in 2010, but we did a version for New Zealand. You can see that in our study, methamphetamine was the second most harmful drug in New Zealand, behind alcohol. This was actually quite consistent with the Australian drug harm ranking study, which had been published a couple of years previously by Yvonne Bonomo and others. One interesting difference, I think, between what we found in Aotearoa and what the Australian study found is, even though methamphetamine was second in both of our studies, we in New Zealand found our scores between harms to self and harms to others were almost equal, whereas in Australia, the harms to others was ranked a bit lower than harms to self. So we are saying that in New Zealand, the harm from methamphetamine crosses across communities and families, and impacts those communities more widely in our assessment. So yeah, there's methamphetamine sitting at number 2. Jai.
Kia ora. Yeah, so as Rose said, those differences in the others were more pronounced, or the difference was pronounced here, and that largely was related to these items up on the screen here: community damage, social harm, and also intergenerational harm, which was a new parameter inserted for our study in particular, alongside another one which was in the harms to self, spiritual harm, which were informed by our Māori worldview here as well. And Rose and colleagues wanted to also include a Māori specific version of the drug harm ranking study utilizing that multi-criterion decision analysis approach as well. However, it was decided that it didn't fit well with the Māori worldview, generally speaking. So I think in brief, one of the reasons that this doesn't align well is that our worldview is very much holistic and highly contextual, and the way that this approach is generally worked is it fragments kind of the harm and doesn't deal with time or causality particularly well. And so instead, went ahead with a wānanga approach. And wānanga is also quite hard to define, but it's a kind of collective knowledge building encounter. Somewhat like focus groups. However, it's underpinned by the epistemological positions of kaupapa Māori research. That knowledge is kind of produced through collectivism or through collective deliberation rather than extracted from individuals in any one context, and that the discussion is active and there's collective problem solving going on, not just talk. And so using that sort of approach, we came up with a different set of findings that are outlined here, and I won't get into all of them as that work is still underway and it's not necessarily peer reviewed. But we're seeing a lot of the background, I guess, to the harm. You can see there the whakapapa of the harm, so the genealogy, what's coming into there, and how is that impacting today from colonization to concepts of intergenerational harm. The breadth of that harm and the different levels at which it operates, and where that could be reduced. The policing or the social policing of pleasure and leisure for Māori, another big contributor here, and also that highly contextualized understanding of drug use that can push something between benefit or harmful, and that's that rongoa until it isn't. So something for our well-being or medicine until it isn't. Next slide. And just to contextualize, I guess, our position at the moment, we've had, I guess, quite a bit of action in the media and in the government with respect to drugs or methamphetamine. And so later last year, around November, we had the Meth Action Plan launched, which very much has a justice orientation. The actual announcement used a lot of combative language, and there's a lot of enhancing of the enforcement around methamphetamine embedded within those plans. Although there is some health support to the tune of around 30 to 40 million, there's still a large abstinence frame, and some of that funding also was said to be going towards a hard-hitting media campaign, which is technically yet to be rolled out. But soon after that, some messaging from our health operational arm, Te Whatu Ora, Health New Zealand, used these ads here. The cot, the dirty cot, the messy room, and the crying baby, which to me is a deployment of kind of stigmatization and fear within the messaging, and not off to a great start as far as reducing harm and taking an informed approach to this work. But this has since been pulled in. I know there's more going on in the background, which will hopefully come out a lot better. And in contrast to that, in March, we had the Substance Harm Action Plan, which was much more broad, very much health oriented, and had a lot of input from various interest holders across the country, and has a large focus on prevention, early intervention, service access, growing the workforce, and strengthening the effectiveness of the actual system itself. So it's interesting to see these dynamics kind of playing out in a short space of time. We have the same government, but with, I would say, a better outlook and a better focus in the more general scope. So we can already see kind of the differences playing out when we isolate methamphetamine on its own. The thing becomes evil within itself, versus when we're looking at these issues on the whole and from a health-based approach. Back to you, Rose, for the next one.
Yeah, sure. So just to make it clear for those of you in Australia, so New Zealand is still very much in relation to drugs in kind of a prohibition space. So it is the legislation is the Misuse of Drugs Act. It has crashed over its 50-year birthday recently. And so methamphetamine is prohibited, and both use and possession and supply are all liable to prosecution. In New Zealand, there was an amendment to the Misuse of Drugs Act in 2019, which said that for personal possession and use, that police had the discretion to take a health-based approach where that would be more beneficial. Right? So I would have argued that at that point we should never have had another use or possession conviction ever again, right? Because when would a health-based approach not be beneficial for someone? But of course, that's not the case. And part of the issue with this is because it's this kind of quasi sort of almost decriminalisation environment, but it relies very much on police discretion. That discretion has not been equitably applied. And so we are seeing that there are still increased rates of arrest and conviction for Māori compared to non-Māori, even in this kind of place of police discretion. So we have a old piece of legislation, but we have got so many reports that indicate that we shouldn't have this anymore. So there was work done over 15 years ago now by the New Zealand Law Commission, which said that the Misuse of Drugs Act 1975 should be repealed and replaced by a new act, which should be administered by the Ministry of Health. That never happened. We've then had a significant review of the mental health and addiction legislation and policy settings, which emphasise the need for a move towards a health-based approach to drugs, which didn't happen. We had work done by the Helen Clark Foundation and the New Zealand Drug Foundation now about 4 years ago, which was a significant review about what would minimise the harm from methamphetamine. And this concluded we must do what works instead of just trying the same tired old approaches. We must focus relentlessly on harm minimization rather than just locking people into a cycle of addiction and incarceration. Just last year, the New Zealand Drug Foundation released a really impressive piece of work on safer drug laws for Aotearoa New Zealand, which is effectively a model for what our drug laws could look like. And they conclude that our current drug laws do not serve their intended purpose. Instead of protecting health, they entrench stigma, expose people to unsafe illicit markets, and perpetuate deep inequities, particularly for Māori. And some work that I did last year with the Helen Clark Foundation suggests that the public is actually with us on this in terms of wanting a health-based approach to drugs. As part of that study, we did representative polling across New Zealand, and we asked people if $100 of your tax was being spent responding to illegal drugs, how would you like it split between supply reduction, treatment prevention, and harm reduction? And people put almost 2/3 of their hypothetical $100 towards treatment, prevention, and harm reduction, collectively a health-based response. They put only just over 1/3 towards justice and policing and enforcement, when in the actuality is that over 2/3 of the money actually goes towards those areas at the moment. So we've got a significant funding gap, but the public is there and is looking for change. So what we have been thinking about is this idea, that we keep seeing these words, right, in reports, and I showed some of them before, this idea of a health-based approach to drugs, or a health-centered approach, or a public health approach to drugs. But up until fairly recently, there hadn't really been a lot of work done, particularly in a public health approach to drugs. Like, what does that actually mean? And so in 2023 and 2024, a couple of really brilliant papers came out. Both of them are from Canadian teams that started to look at what does a public health approach to drugs look like. And I've put the references there below, but to summarize, what they're saying is that a public health approach actually incorporates a whole bunch of different aspects. It incorporates prevention and harm reduction. It includes regulation and legal and policy settings, recognizing that those are a source of harm. It means that we need to put more emphasis on the determinants of health. It is inclusive of treatment, and that also stigma reduction must occur alongside all of this in order to enact a public health approach. What they also conclude is what a public health approach isn't. And what a public health approach isn't is a criminal justice approach to drugs. So, and then back to you, Jay.
Thanks. So that kind of takes us towards our study, which after a good amount of discussion, I think you would say, Rose, we landed on kind of this overall question of what could a public health approach to methamphetamine look like in practice here in Aotearoa. And so when we think about how we could frame that up and doing some reviewing of the literature, what evidence exists for public health aligned approaches? What's out there right now? What can we say? And so this led us down the path of conducting what I'm calling currently a narrative review of reviews with additional inclusion of studies related to particular approaches. Now, for this webinar today, mainly going to be talking about the Indigenous approaches and a little bit also about the harm reduction approaches because they're a key pillar of that public health approach. However, from the review of reviews, there's also going to be a significant amount of treatment as well coming through there, as well as some other little bits and pieces from the other pillars, but the harm reduction and the treatment are the ones that we're going to be really seeing coming through today. And ultimately, this is to present that evidence-based set of interventions. And so in terms of our methods, we kind of split it up in terms of the systematic reviews, as I'd said, and the others. So for the systematic reviews or high-level reviews, we just wanted to get anything that measured impact of any approach, really, that sought to address methamphetamine and particularly methamphetamine-related harm, whether that was for the consumers themselves or for other people. We had to be a bit careful about how we did this, and so we did include some reviews that were covering stimulants more broadly, as long as we could pass out the methamphetamine-specific outcomes. And as we had said, based on our public health approach, we were excluding anything that was criminal justice or supply reduction in particular. And if it was too general, we didn't include it, and or if it only included one study, of course, because then it's essentially not a review of multiple studies. And then for part two, we were looking at all of these different areas. Now, it can seem like a lot, but we knew going in a little bit that there wasn't necessarily going to be a huge amount on some of these, maybe a more significant amount on some of these. So ones that are older, more established, like needle and syringe programs, that we feel or we say that they work. We've kind of done a lot of work in this area, but perhaps not so much specifically with respect to methamphetamine. Other ones like drug checking or safer supply, kind of more emerging. Not everyone's doing them or has the ability to carry these out. And so we want to look for positive signals there potentially as well, particularly because these are aligning with our harm reduction approach. And we also wanted to look at the alternatives to the traditionally punitive approaches. So whether that's decriminalization, depenalization, all these different phrases that we might think fit or align with that as well. And so again, in line with harm reduction, we didn't want to include anything that purely utilized coercion or encouraged stigmatization within the initiative itself. So for example, if there was an educational evaluation of some educational program that encouraged or utilized stigmatizing language within the actual initiative, that was something that wouldn't be included either. And then again, we wanted to really see outcomes, and so we weren't particularly interested in people's willingness or their needs per se, or purely descriptive stuff, and also no modeling studies. We just wanted to see what exists out there right now. So everything was in English, human specific, of course, and published from 2010 or forward. We searched a bunch of databases. Originally did this search back in July 24, but recently reran it again for an update last month, and also did some grey literature searching back in 24 as well, which is due for an update. So again, this is tentative at the moment, and we did loosen our criteria a little bit up to include methamphetamine just to give us a bit more breadth. But ultimately, across those different categories, I screened about 16,000 records and landed on these numbers of studies. So it had 82 systematic reviews or high level reviews, mainly of RCTs of particular treatments, and largely samples dominated by males amongst those RCTs. At the moment, so again, these numbers are tentative, but we've included an additional 56 methamphetamine related studies across these different approaches or initiatives, which I will briefly try to touch on in the remaining time. So, in terms of the systematic reviews, the psychosocial approaches and some key takeaways from those, probably one that people are becoming more and more familiar with, but contingency management is the one that's consistently found to reduce consumption or increase abstinence and also improve treatment retention. There was also support for cognitive behavioral therapy and some threads of support for motivational interviewing, although this was quite limited when used alone. And then also when we have really more intensive psychosocial programs like the Matrix model, we also see some threads of or some signals for support there too, but a little bit more mixed. In terms of pharmacological treatments, which have also been back in the spotlight more recently, particularly in Australia, these often included psychosocial adjuncts, but just talking really about the pharmacological stuff now, there was really mixed success for antidepressants, quite all over the place, and no real consistent positive thread. Similarly, for psychostimulant medications themselves, like dexamphetamine or methylphenidate, although quite a recent review indicated, again, on a very low sample of studies, that higher doses tend to have higher treatment retention and potentially greater reduction in use as well. And there is good evidence for acute use of some drugs in particular situations like acute psychotic states in which somebody's ingested a lot of meth. In terms of some of these other initiatives that have been reviewed, we've got neuromodulation, and this is primarily looking at its impacts on craving, generally speaking. And then we did see reductions when looking at both transcranial direct current stimulation and repetitive transcranial magnetic stimulation when compared to sham, but there wasn't really much long-term follow-up with these. And actually also deep brain stimulation had some really positive signals too, but that was only with 3 cases and not something that we're about to see become really widespread. In terms of exercise, which was primarily aerobic, there were some, again, positive signals primarily around reductions in craving and some quality of life benefits, which we'd probably expect from exercise more generally, but little evidence regarding like changes in use otherwise. And there was a smattering of other interventions like mobile phone, some mass media, some other things. And again, there were some positives there, but nothing super exciting, or nothing to write home about necessarily. There were some positive findings for text interventions relating to safer sex, for example, in people that use methamphetamine. But again, these are kind of only a smattering, not really reviewing too many studies and not much impact for methamphetamine itself. Now, in terms of the Indigenous approaches specifically, here, again, we didn't find too much with respect to methamphetamine, but there were a few studies. When I say a few, at the moment, there's only 6. So the first one was just basically covering 3 cases of community-based therapeutic program based on the practices of the Yaqui people in Mexico. Now, their practices are quite diverse, and they will include, in some cases, the consumption of ayahuasca, so the classical psychedelic containing brew. But here there were positive outcomes, and I know that this area is getting a lot of hype at the moment. So, wanted to really just get into that a little bit more. That's not the only thing they're doing, and they're utilizing other traditional approaches like sweat lodges, smudging, etc., things of that nature. And then the rest, as far as I can remember, are from Australia. So woohoo to you guys. I'm probably not telling you too much that you don't already know about some of these as well. But we know that community reinforcement approach in one study in rural New South Wales was able to assist with amphetamine use and improve people's mental well-being and empowerment at 3 months, which is good. It's a pretty decent follow-up as well. And also a family wellbeing intervention, or Aboriginal family wellbeing intervention piloted with workers was also good for increasing their wellbeing and their empowerment, and was also rated as highly relevant, although I'm not quite sure where that specific intervention is sitting right now. For the remaining ones, we have this study by Nathan et al. In 2020, which I've put an asterisk beside because they describe it as holistic, and at the moment we're including this particularly because it focuses on Aboriginal and Torres Strait Islander adolescents aged 13 to 18. It's a residential treatment program that was quite Indigenous informed, or more, it took a more holistic framing within the programming, which is why we've currently got it included. And there was some benefits there for amphetamine type stimulant use, but also self-harm and suicide attempts and arrest. However, the authors themselves are a bit they're not quite so strong in their language around how much of an impact this particular residential program has, or other things that are going on at the same time. More recently, the We Can Do This app, which is the specific web-based app for Aboriginal and Torres Strait Islanders who are wanting to reduce or stop methamphetamine use. In an RCT, there was no significant effect on the meth use or psychosocial well-being. However, this is largely put down to quite poor engagement with the app itself. And then Scale C, which is quite a different one, but we've included it here because it is a test entry Hep C intervention delivered straight out of a Aboriginal controlled, community controlled health organisation. So it's embedded within that Indigenous organisation, and essentially a la typical, if you will, test entry interventions. It worked really well with the population involved with really high treatment uptake as well. Okay, I'm not going to talk too much about the remaining ones because there's quite a lot of differences and details that go all over the place, but I do want to cover them really briefly just to highlight some key takeaways. So around education, seems to be, unsurprisingly, that peers are really important for this, particularly around communicating risk reduction information to each other through distributed networks. There's also a study recently that showed that stigma reduction workshops for professionals can be effective at reducing stigmatizing attitudes, particularly when a case uses stimulant use disorder within its kind of workshop programming itself. And a big shout out, of course, to Cracks in the Ice, which is another initiative that we've seen do something positive. We've seen naive people visiting the website, increasing their knowledge and reducing stigmatizing attitudes towards methamphetamine. So that's fantastic to see. Drug checking, a lot less on this specifically with respect to methamphetamine, but largely being used and influencing positive behavior change when people are interacting with drug checking to avoid fentanyl in the North American context. In terms of NSBs or safe injection, we found here in Aotearoa that there were one study showed that our peer-led NSBs allow for better health info exchange. People interacting with those services have greater life satisfaction and also better mental health. And access, of course, to the needles and syringes can reduce sharing. And unfortunately, there's also evidence that taking it away in North America can, again, up, unsurprisingly, the reusing of syringes, but also reduce the HIV testing and the access to naloxone as well. And then one of the novel ones, safe inhalation, we found that limited access to pipes increases the likelihood of injecting methamphetamine, and that a large minority, I think around 44%, people who injected methamphetamine in one of the samples with access to the safer smoking equipment actually reduced their injection frequency. So there's some balancing of harms there, or some weighing up between injection and smoking as well. Next slide, please. For the drug consumption rooms, again, not a whole lot specifically around methamphetamine, but we know that injection daily methamphetamine injection is associated with frequent site use, which is also associated with reduced all-cause mortality. So that's a really positive sign for drug consumption rooms, even with respect to methamphetamine. Safer supply, which is basically all out of Canada. There's a whole bunch of little pieces of evidence here, but one of the big ones I wanted to highlight was the stimulant prescribing program out of Ottawa. They did a chart review, and they found that with the prescribing, there were significant reductions in both meth use from something like 1.5 points a day to 0, and improved primary care access, and that was from something like 25% to 90%. primary care access, a really significant jump there. Now, of course, this is with a really small sample, but we need to be thinking, I think, about what that means, and the way that that's functioning relative to perhaps our treatment trials that we're using similar similar substances in. And then for our alternatives, now Te Oranga, this is a whole seminar in itself, but I've kind of dubbed it decrim light because there was an emphasis on the police discretion here, and this was rolled out in Northland here in Aotearoa New Zealand. And it was a complex intervention with many moving parts and a whole of community approach with iwi, health services, NGOs, and of course the police. But ultimately, the evaluation report found a 34% reduction in crime relative to the treatment as usual. And our only other real major example that we could find was around British Columbia and Canada, where they had a period of decrim. And that reduced psychological distress for people that use methamphetamine, though it had kind of mixed effects on stigma. So people reported positive and more positive interactions with law enforcement, for example, but sometimes worse interactions with the public due to kind of an elevated awareness of public drug use. And no impact really of those changes on stimulant-related hospitalizations or deaths. And unfortunately, the recriminalization reversed those gains in the psychological distress reduction. We're there.
Oh, so some of the caveats and the limitations to all of this. Firstly was, Jai talked about screening 16,000 records, and for many of them, there was an awful lot of redundancy within what was found, and many reviews, I think particularly in the treatment space, I think, Jai, had very slight differences. So yeah, a lot of evidence without necessarily something new. And within the systematic reviews in phase 1, abstinence was the primary outcome measure in the majority of RCTs. And so there's kind of this weighting of the evidence towards abstinence-focused treatment, and less on harm reduction and stigma reduction and all of those other parts of the wheel that sort of sit around a public health approach. And despite there being really positive signals for harm reduction, there is a significant amount of evidence gaps that are apparent throughout, and the body of evidence for harm reduction is just so much smaller, particularly when we start to talk about Indigenous harm reduction compared to the body of evidence for treatment approaches. We also found that because we had a focus on methamphetamine, which was intentional, but it sometimes meant that we got limited evidence back, that there were interventions that were focused perhaps on stimulants, and that then we were trying to tighten down to methamphetamine, but also the harm reduction approaches, some of them are less applicable to methamphetamine, and so by trying to focus on methamphetamine, we potentially excluded some evidence because of that. Do you want to jump in here, Jai, to talk about some of the Indigenous approach limitations, or do you want me to keep going?
Yeah, no, for sure. I think one of the big things, I guess, to keep in mind with respect to the Indigenous approaches is that our way of seeing the world, or Indigenous ways of seeing the world, often are so holistic that there's no feeling that there needs to be a distinguished, like any targeting specifically of substances or to distinguish between any particular consumer groups either. And so that can also limit our evidence gathering with respect to a Indigenous specific approach, because of our criteria that we had. We might be missing out on some initiative because it was just talking about people who use drugs more generally and didn't report on them separately, particularly around quality of life and community engagement and those sorts of things. And then there's also these other kind of bigger picture things going on, like a general lack of resourcing from governments, etc., funding particularly interventions, but also the evaluation of those interventions. And so Indigenous groups, organizations, etc., might reorient their priorities and not actually even write up their reports, even in grey literature, for example. And so we might not see them there, even though they might be going or working well on the ground. And there's also these epistemological, evidentiary kind of tensions going on about what counts in terms of evaluation. What's the ways in which we know that this thing is working for these people? Is this something that a Western government will buy into if evaluated from this perspective, for example? And these things are constantly going on, and something that is not necessarily resolved. Although I will note that we do have our own kaupapa Māori evaluations going on here too, so we know that we can do these things in different ways. Did you want to take that one?
Yeah. So another thing that we really found in terms of limitations was that we couldn't find an awful lot. We went looking for interventions and programs that were specifically intended to support family and whānau. And when we did the drug harms ranking study and found, which put methamphetamine at number 2 in Aotearoa, so as Joe mentioned earlier on, a lot of that harm was being driven out of what was occurring, the harm that was accruing to family and to community, and yet so many of the interventions are targeted at the individual. And so we kind of went looking for programs that were intended to support the wider family or whānau, and that's something that is a developing area and one that we'll be watching with great interest, but is currently a pretty significant knowledge gap. And similarly, that there were some positive signals for destigmatization. But yeah, more work needed there, particularly in a New Zealand context. I guess we're coming to the end, and these are, I guess, the big questions, right, that weigh on our minds collectively. And that Joy and I talk about and have no necessary solutions to, but wanted to flag and kind of show you where our heads were at in relation to this work. That if we're calling this a public health approach, and trying to define what a public health approach to methamphetamine would look like in Aotearoa, but if a genuine public health approach would focus all the way back, right? It would have an absolute focus on the structural determinants of health, which sit far below or underpin drug use and drug harm. This is things like poverty and marginalization and intergenerational trauma and colonization, and we know how much of an impact those have on methamphetamine use and harm. But there's not going to be any interventions, or there's no evaluation of what it looks like when we try to remove poverty in Aotearoa, right? So yes, we're saying a public health approach has all of these elements, but there are still limits to how far the evidence will allow us to go. And I think there is still so much work to be done on the structural determinants of health, but it's hard to evaluate. We also want to emphasize the difficulties in interpreting knowledge gaps, and that a lack of published evidence is not lack of efficacy. And that, as Joe mentioned, there's really diverse resourcing constraints that are put on different sectors, and clearly, a promising pharmacological treatment is more likely to have RCTs conducted and have studies and to be published than a community-based harm reduction intervention, which might be doing absolutely phenomenal work and be really achieving positive change, but isn't necessarily going to show up in the literature. And so, we want to emphasize that when we put up the number of studies, that doesn't mean that these harm reduction approaches or Indigenous approaches are not working. And the last big question that we keep circling back to is, within a public health approach, how do we actually consider and incorporate motivation and benefit of drug use alongside harms? And public health obviously has, public health's got a reputation for being a little bit finger waggy, right? Like, public health's got an uncomfortable relationship with pleasure. But if we can't talk about pleasure and motivations and benefits when we're talking about drug use, we're not going to get very far. And so how to kind of build that thinking into a public health approach to drugs is a huge body of work that is still to come, but I think is something that really needs to be tackled as a field. So what could we do in Aotearoa, based on the back of this work? I think we need to really invest in some of these areas of promise and get really creative about how we think about and what is funded and what is supported, and how great interventions can be invested in and evaluated and kind of contribute to the body of knowledge. We absolutely need to strengthen the research and the funding for Indigenous approaches, and those need to be by Māori for Māori and consistent with Te Tiriti o Waitangi. And there is obviously, and there's an underinvestment in all areas of drug use, but certainly in Indigenous approaches, there is not enough money in the system. And to take a wider view of evaluation and evaluate in diverse ways within a local context, paying much closer attention to what types of knowledge or the ways in which we know things, so that we are not being exclusionary in our body of evidence, but are instead more welcoming and building knowledge based on diverse perspectives and views. So yeah, this is those are our key messages that we will keep communicating through all of our policy and advocacy networks. But ultimately, the intent of this work was to try and give for Aotearoa a bit of a roadmap. Like, if we're saying we want to take a public health approach to methamphetamine in New Zealand, which all of those reports that I put up before have effectively done, to be able to say, well, this is where the body of evidence sit. These are the things that could be invested in here to try and enact and achieve that. Hoi, okay, all right. Unless there's something else you want to say on those final slides, Jai, then I think I'm going to unshare and we are up for a whole bunch of questions.
Thanks so much, Rose and Jai. That was fantastic. And so many parallels with what we're seeing in Australia as well. Particularly, we've got our drug action plan under review at the moment, and the government is really thinking about how we can better capture evaluation more broadly, because within specific AOD treatment services or specific programs, they're seeing amazing results, but that's not being published or collected in any way. So there's no way to really harness it, and it seems all very piecemeal. So if we could get a way to increase just communication across the sector, would be amazing. And I love the touch on the importance of also addressing those underlying structural and social determinants. We can only put so many band-aids on things before we need to really look at what are the drivers behind what's actually happening. How can we better support people holistically and as the whole person, not just looking at one specific thing. So yeah, it was an amazing talk. Thank you so much. One question that really popped to mind, but I will encourage everyone who is on the line to also put in any questions that you have, is you touched a little bit about families, and that's something we also see more broadly across the AOD sector and internationally, is there's not a lot of focus on how to support families. And yet we know that families are so important in the recovery process, particularly we've seen in stimulant recovery, and also the value of peers. So, if we were to, was there anything that popped up in your review or when you were thinking about it, how we could better support families? What might that look like?
I think I'll jump in. We, I think it's fair. I mean, it's particularly when we did our initial search, there was very minimal, and I know that you guys essentially over in Australia are leading the way, I think, in developing that space a little bit more. I mean, I think it was even coming along to one of the other seminars. I think was it by Claire talking about supporting families. So I think there's so much to be done. How we would go about that here may look quite different to how you would go about that, particularly from a Māori perspective. And I think that's why we see that difference in our actual harm, the way that we weight our harm or the way that we grade our harm as well, because of that community, the importance of that, or the emphasis on that and that collectivism, and how much that impacts people beyond the person who's experiencing drug-related problems too. Um, and just anecdotally, or through some of the conversations I've been having, that's been so important for people, the integration of their whānau into their recovery journeys, or even just supporting them along whatever it is that they think is the best way forward for them personally, and having that greater understanding. And so I think that overlaps considerably with like the knowledge and the education as well. And again, I think that also needs to go back to the structural socioeconomic determinants, and also for us, and likely for you guys to a really strong understanding of kind of that historical and ongoing flow-on effect of colonization, essentially, and how we have had a major and ongoing event contribute significantly to some people more than others, and that's just permeating harm in a way that we need to really acknowledge and then collectively take the responsibility to kind of move forward with that, and address it, and yell at our respective governments to support us to do that too.
Any thoughts from you, Rose, about what that might look like?
I think, leading on from Jai's point about, particularly about intergenerational trauma and the effects of colonization, I think in New Zealand in particular, I think if we're thinking about destigmatization more actively, which we should be as an intervention, I think it has to be very much framed in that way, and acknowledging some of the ways in which harm has been created and perpetuated. And I think there's often some very there's a lot of kind of deficit framed kind of messaging about people who are experiencing harm from methamphetamine, and reorienting that towards understanding those structural determinants, I think will help, and will more broadly help not just families, I guess I'm saying, but this is what helps communities come together to try and solve this problem collectively, and that an approach beyond just the family group, but that looks to empower communities and have this real strengths-based approach about what is amazing about these communities, and how does a collectivist approach actually uplift and support people, particularly those who are experiencing harm from methamphetamine. But that would come back to a whole bunch of those structural determinants around stigma and marginalization and poverty and, yeah, capitalism.
Yes, yes. And I found it interesting that one of your findings was that there's so much support from the community for more harm reduction. So yes, why aren't we then seeing that translating into better policies is a great question. Couple of questions that have come through, and Jai, thanks for answering them as well. I love how you can do multiple things at once. I am not one of those people.
Don't want to leave anyone hanging.
No. Well, we better get cracking then. Faye was wondering, have you evaluated how a cultural framework in treatment impacts abstinence?
Us personally, no.
Or maybe no. Was there any sort of cultural frameworks that popped up when you were doing your review, or?
Not strictly speaking. And again, I don't think that means that they're not there. I mean, I think I can think of a recent example, not necessarily explicitly relating to methamphetamine alone, but I can think of recent examples where people are applying these frameworks, or even just kind of throwing out the window any kind of meaningful Western ways of being and doing, and just running a program in which people are attending with drug-related problems, but not necessarily even targeting them specifically, and using their way of being as the framework, which ultimately results in reductions in drug harm and increasing abstinence in some cases, but haven't really seen them be, I guess, evaluated, if you will, in the traditional sense.
Yes. And I guess that comes back to what do we consider evaluation and
Mm.
collection of measures, which kind of leads on to another question that we've sort of got about. Well, do you have any thoughts on creative ways, I guess, to evaluate programs or measures in any way, whether that be more qualitative or longitudinal? What do you think would be, if you could have your wish list around how you might evaluate things, what could the components of that look like?
I mean, I think to start with, I think that for me, evaluation starts with the measures of success, right? Like what are we evaluating against? How do we define success? And from my perspective, those metrics of success should be coming from people who use drugs, right? That should be coming from the people who are using the service. So to me, a really positive evaluation, everything flows. You design your evaluation effectively backwards from what are we calling success, and those measures of success must be informed, must be from the people for whom the service is intended to benefit. And if we did that work always at the start, I think that would lead to different outcomes being seen as important. Um, in terms of the ways in which we evaluate, yeah, absolutely. We're bringing in more qualitative evidence, and I say this as a quant person, but I am coming to the dark side of qual.
You're becoming mixed methods.
I am becoming very mixed methods. And I think that having the qualitative work running alongside is incredibly important, particularly when we are wanting to use evaluations as part of advocacy efforts, right? Like data doesn't change anyone's minds, but stories do.
Yeah, absolutely. I think I would just totally agree with that. The narrative stuff is what really hits home, isn't it? It's what we remember. I'm constantly forgetting numbers, but quotes, yeah, they stick with me. And I think, yeah, in particular for me, I don't think we should be aiming for abstinence. Just like it's that simple for me. In terms of our evaluations, our primary outcomes don't need to be this framed in that way. And I'm of the view that we should have more diverse secondary outcomes, and we should be just looking for those signals wherever they may be, because I think a lot of the time that stuff's working or it's being helpful at some point along the journey, and they're stuck doing that one thing and then they move to another thing, and that thing helped them get to that next point and on their way or on to the next thing. And I think we really miss that, and we're potentially throwing stuff out because we're like, oh, didn't increase abstinence, sucks, move on. But it actually had some really nice other secondary effects. So yeah, more to do.
Yeah, I definitely agree. I think we need to be focusing more on the quality of life outcomes. And as you say, Rose, like what is the actual outcome that the people who are wanting to reduce their drug use are seeking? Is it just to better manage? Is it, what is it that they want and how can we evaluate that? We know that there's been some research around using ADHD medication as a possible pharmacological substitution therapy. Um, and I think from memory, but you would probably know more because you've just done the review, there is a little bit of evidence, but it's still in development, isn't that correct? They're still undertaking the trials.
Yeah, I think with respect to a population of people that have undiagnosed or untreated ADHD, I think that's something that's like completely untapped. Um, I think there's some estimates that there's a considerable amount of people that have dependence issues with methamphetamine that just have untreated ADHD, and that's part of their treatment regime, if you will. I think one of the thing this again, it's a whole nother webinar. You've had plenty of discussions with other people who are more in the space than me or Rose, but the ways in which we conduct our kind of clinical trials with people who are particularly using a lot of these substances, we're not even touching the sides with the doses that we're giving them in those trials. And so why should we expect them to change their use of illicit amphetamines? If we don't completely swap out exactly what they use and then start tapering it down, why would we see
Yeah.
any difference? So there's a lot of other questions to be had there too.
Yes, I think we'll just finish on one last question, which is following up to that one. Like, are we also looking at, and I think you touched on this with the social determinants, factors that are leading to methamphetamine use, in whether that be undiagnosed ADHD or trauma, and if we do look at those under identifying factors, what kind of flow-on effects might that have?
I mean, yeah, so are we focusing on underlying determinants? No. I think when we invest in prevention, at least in New Zealand, to be honest, it's pretty crap. It's sorry, Friday afternoon. That was sorry. It's not very good. So there's a lot of investment in education or in public health messaging that says, methamphetamine is bad. And so there is not at the moment an investment in those determinants that contribute to methamphetamine harm. But as I said, trying to argue for within a health budget to say, okay, within a substance use harm reduction plan, we'd really like you to support people's housing and improve job stability, and if you could fix the the impacts of colonization too, that would be really great. Like it's really hard, right? That doesn't mean we shouldn't do it though.
Yes.
Yeah, absolutely. I think I still find myself being unable really to see problematic methamphetamine use as anything other than a symptom of all these other issues. And if I was the king of this country, I would kind of just ignore focusing on it and fix all those baseline things, as I'm sure many of us would in public health. And we would see a major reduction in a whole number of different issues. But it's not that easy.
Sadly, it's not that easy, but I guess one of the good things about this conversation is it's brought out how interconnected everything is. And so, touching on just one thing is probably not enough when we're looking at a public health approach. We need to be broadening our context and thinking more about the wider picture. Well, that's everything that we have time for today. It's been fantastic, Rose and Jai. Thank you so much for your time. We really appreciate it. And thank you to all our attendees. I hope that you've found this webinar as valuable as I have. And I hope everyone has a wonderful rest of the day. Thanks so much. Bye.